behind ECG and what are the things, deeper concepts, certain number of things why we don't understand ECG. But I'll be talking about most of the normal ECG. We'll have some other day to discuss about abnormal ECG. That will be vast of interest when you understand a normal ECG first. So let's go into the things. The contents of today's program will be action potentials and how they are generated by the myocardial cells and the nodal tissue as well. And we'll be also covering the contents of ECG waves, so and all intervals, segments, all these things in the set book. Okay, so fine. You here see a quote here. If there are no ups and downs in your life, it means you are dead. So you understand ECG is like this. The waves are like this. They should not be a straight line. If at all there is a straight line, that means you understood the person. The trick, life is full of ups and downs. The trick for us to enjoy the ups, we should know the trick for us to enjoy the up and have the courage during the downs to come back to the top. That's what I advise. And this quote, if there are no ups and downs in your life, it means you are dead, is pretty given by a famous person, Ratan Tata. So he seems to tell always have things ups and downs. So right, we are going into the electrical system of the heart, how the heart beats with its electrical activity, right from the womb to the tomb. That will be rather interesting. Right from the womb to the tomb, generated electrical impulse generated. We have certain generators in the heart which conduct electricity until we are dead. That's of obvious interest. If that doesn't work, there is a straight line. So coming to next concept that we have, this system of to tell you conducting system from the sinoatrial node and next the AV node, although we have internodal pathways there, and AV node, the bundle of His, which is called AV nodal bundle or the bundle of His. And then we have both the branches on the left side, which is more obvious, and the right side also right branch, and and also the Purkinje fibers in the head. So all of them, if one doesn't conduct, the next one takes over. That's called the natural pacemakers. So fine, here is the picture. So pretty much the basics. I should go that cardiac muscle, the diagram of the cardiac muscle shown to you at the top of picture here, which shows there is a different cell muscle tissue like this, different cells, obviously one after the other, and the primary concept is cardiac muscle is a syncytium completely. Why we call this syncytium? Because they are connected by gap junctions, lot of gap junctions, not one, two as seen here, but lot of gap junctions which encourage communication between cells and to generate the action potential one after the other. It doesn't mean that the sinoatrial node has to go and kickstart all the cells one after the other, or stimulate all the cells, pinpointly stimulate all the cells, but rather stimulation of one cell from this point of view. If it stimulates one cell from here, one cell is stimulated from here, let's consider this is a sinoatrial node. If it is stimulated from here and the message is conveyed, or the next cell is trickled, and so information is conveyed further. And next go and to think about this is a diagram rather showing us about this atrial and the ventricular tissue, and we see that atrium, both the atrial tissue, the right atrium or the left atrium, they are separated by a wall, and but rather this wall is a conducting wall. So atrial tissue is a separate tissue, and a ventricular tissue, the beat, or we call it the right ventricular or the left ventricle, is a separate tissue to the atrium. So between that they have a tissue or atrioventricular junction, which all this is mentioned in the color over here. Totally all this point, all this tissue is called a fibrous annulus, which rather lets us to stop any conveying of message between the atrium and ventricle. All the message from the atrium, all the conducting electricity from the atrium to the ventricle should pass only through the atrioventricular node, rather than passing everywhere they can in different directions, which should not happen. So that is the reason why we have so-called fibrous annulus, or a fibrous tissue, which does not allow the conduction of electricity from atrium to ventricle. There is only one way, that is a bridge, or a tunnel through which the electrical wires are passed, and which is passing through the atrioventricular bundle or the AV nodal system here. Only this is a single, rather sometimes if it is abnormal, it can go back, called the re-entry phenomenon if the things are abnormal. So if things are abnormal, rather if there is an interruption in the fibrous tissue on either of the sides, that is, and the electricity is conducted from this corner of the left atrium or this corner of the right atrium to the right ventricle. So that system is called bundle of Kent, or a Wolff-Parkinson syndrome, which is more dangerous to the person to live further, and this is a pathological case. Let's talk further about the next streaming thing is about how the sinoatrial node here, sinoatrial node is present in this tissue, how it is conveying its message, or electricity is passed to the next tissue, how they respond. Rather in this we see a heart having a conducting of impulse from the sand, and it is conducted all over the atrium, not only through the internodal pathways, but the most important point is when it is conducting through the internodal pathways, it is faster rather than through the atrium, which is spreading to every point, because the internodal tissues or the pathways cannot conduct to every cell in the atrium. So they should conduct to one after the one cell is stimulated, it has passed on to the next cell. That's why we called it as a sensation. So that is it. Sinoatrial node is conducting. Let's take one point of the tissue from the ventricle, because this ventricle is more understanding and a complex thing. Let's take one part of the tissue from here, ventricular tissue here. Let me choose one tissue, big tissue from the ventricles, and see one cell. Let's consider one cell and go into understanding of how the action potential is generated. So this is you have seen in the first year, and most of the first years might be also in this, that you have been discussed recently, and the other course people, this revision for you, and what is really happening in the action potential, how it kicks off a kickstart. So you should know, let's consider this a ventricular tissue, a ventricular cell or a atrial cell. Let's simply, for a better understanding, let's consider this a ventricular tissue, and we have a resting membrane potential for any ventricular tissue or a atrial tissue as minus 90 millivolts. Please underline that. A resting membrane potential, I will differ with the pacemaker potential, which has a different resting membrane potential, but here for the atrial tissue and the ventricular tissue, the resting membrane potential is minus 90. That we should note. So once there is a resting membrane potential here, and suddenly we have a kick point from here, suddenly we have a stimulus being given from the tissue, from the next tissue, sinoatrial node, or the next cell which is conducting any electricity. Immediately what happens, sodium ions trickle in because there is a stimulation. So certain small amount of sodium ions are stimulate this thing, because why we call it minus 90 millivolt, because the cell is the potential difference between the outside and the inside, the charge is the minus 90, whereas inside it is more charged, I mean more negatively charged when compared to the outside, and it is minus 90 inside when compared to outside environment. So wise, when the cell is trickled immediately, so sodium ions trickle in, certain number of sodium ions trickle in, taking this potential in the ventricular cell to around minus 70 millivolts. That is called a threshold potential. This is the minimum amount of potential needed for the cell to get depolarized further. If at all, only a small amount of sodium ions are trickling in, causing it to change from -90 to -80. That is not called a threshold potential. Threshold potential is a minimum amount of potential or the minimum amount of charge for the cell to get activated or depolarized. That is the minimum called threshold potential. That's called -70 millivolts here. The threshold potential we are talking about here is the -70 millivolts. So at this point, this is called a threshold potential. At a threshold potential, now sodium sodium channels open at this point at -70 millivolt. There's a sodium faster gushing sodium channels are open, and immediately there is a gushing of sodium because it is more positively charged outside when compared to the negative. Lot of sodium ions move in a rush into the cell, causing the cell to take it over from -70 to -60, -40, -20, further to 0, and further on to +20. It is taking the cell completely in a depolarization. That is called a phase of depolarization, or it is called phase 0. Kindly remind yourself, it is phase 0. It is called ventricular depolarization, taking from a -90 charge towards a +20 charge, crossing 0 towards a +20 charge. Whenever the cell has gone to a +20, now the sodium channels are closed. To remind you, the sodium channels at this point should be closed immediately, at this very tip of this. At this point, when the sodium channels close, that starts the so-called the phase 1 of repolarization. That's called phase 1. Immediately at +20, the cell is +20 charged inside when compared. So wise, what happens now? There are more potassium ions, positive potassium ions inside, so that the potassium there at this point of +20, the sodium channels close and the potassium channels open up, causing the potassium to move outside. A lot of potassium moves outside the cell and cause the voltage of the cell to fall down to 0 back again. And a balance between potassium and a calcium, and also later the alone activity of the potassium, which is called rapid repolarization, where the potassium is going out, and then phase 4, where the resting membrane potential is being re-established to a normal phase, and a balance of what is sodium, which is inside now, is taken outside, and potassium, which is outside, which has gushed out outside during this phase, is coming in. That is called sodium potassium 80 phases. And then this phase of 4 is maintained by the transmembrane potential, is maintained by potassium channels primarily, because there is leaky potassium channels which is taking place in phase 4. So we have different phases: 0, 1, 2, and 4. 1, 2, 3, and 4. We should know which is depolarization. The activity of action potential is comprising of depolarization and different phases of repolarization. As this depolarization activity starts, immediately within few milliseconds there is a contraction of the heart, and repolarization starts. Within few milliseconds there is a relaxation of heart, which normally takes place. That is for our understanding in this action potential. And then we have to go on to see these different phases in a different slide, all these phases for your better understanding. Action potential consists of depolarization and repolarization, and which should take place for a certain period of time. And after the initial depolarization activity, the starting of depolarization activity, after few milliseconds, there is a starting of a contraction. After contraction, there's a few during repolarization, there is also a relaxation phase. Okay, so and the below picture is showing us the permeability of the different ions, which I will not go into details of sodium ions, how potassium ion, which is maintaining the transmembrane potential here. Later on, sodium takes on during the phase of depolarization, and then later on taken over by the calcium and the potassium balance at a certain phase, and then taken over by the potassium alone. Lot of potassium is going out, so we have a curve here, potassium going out, and later on maintaining the transmembrane potential. That's a job like this. Potassium is sustainably maintaining the transmembrane potential or the resting membrane potential. And now slide to show here is about
one other thing, the refractory period, which is very important concept for you, which happens during depolarization and repolarization. Once the myocardial cell have entered the phase 0 of repolarization, the cells now become refractory to the conduction of an incoming impulse. Now this allows the cells to recover from depolarization. So the relative difference between the refractory state depends on the state of fast sodium channels here in this. Now the refractory state is generally defined by the strength of the impulse required for the myocardial cell to generate or propagate any action potential. Why we are talking about this? Since they are relevant, they are very relevant to understand the ECG rhythms resulting from the reentry circuits or the for the certain antiarrhythmic drugs to to think about the antiarrhythmic drugs that prolong the action potential, which really happens in certain conditions. Now we here see terms called absolute refractory period, and it is otherwise called effective refractory period. Why is this very important to us? And the relative refractory period during the phase 0 and the phase 1, and in phase 2 and early part of phase 3, that is called absolute refractory period, wherein you should understand that the myocardial cell here is unable to propagate any action potential in response to any stimulus further during this period. So whatever stimulus you give a prick during this period, it is not going to respond. That is called absolute or effective refractory period. For example, after this phase, there is something called a relative refractory period. During this time, from part of phase 3, during this time, early part of phase 3 of repolarization, the cell may respond to a stronger than a normal stimulus. If you give a big prick, now the cell hyper responds to it, and that will be a reason for causing a relative refractory period, and which might cause one other heartbeat earlier. So the below is shown a picture of ECG recording on the body surfaces, and that to be understood. Okay, and coming you have any doubts in between, please try to interrupt me. And coming back to a concept that we have a different kind of action potential here, which is shown into this, and you should understand this action potential here is looking a bit different. This is action potential is generated. I'll show you in the picture here from the sinoatrial node or AV nodal tissue, because the difference between AV nodal tissue or a sinoatrial nodal tissue and a ventricular or atrial cell, because this sinoatrial tissue completely depends on the calcium, whereas ventricular atrial tissue depends more on the sodium for its depolarization activity. But whereas AV nodal tissue or the sinoatrial node, all these nodal tissues depend primarily on the calcium ions for their depolarization activity. So coming back to this, why there is a different shape here, the resting membrane potential as differed from the earlier one, which I have told you, the ventricular, the atrial tissue has a resting membrane potential of -90 when compared to the resting membrane potential of atrial nodal tissue is -60 millivolts, wherein when in -60 millivolts, there is something very important here called pacemaker current. This area is called a pacemaker current, all this area, which I'll try to draw for you with this area. This is called a pacemaker current from here to here. What really happens in this phase, that this, let's call it a phase 4, a spontaneous phase 4 of depolarization. What happens, although it is upsloping and it is slow, the phase is slow inward, sodium current results in a gradual or a gradient gradual increase in the rise of membrane potential, which really happens, taking it to the threshold, which is here, over here, threshold. And when it gets to the threshold potential, and then gets activated the calcium channels open, calcium gushes in, but it's a slow process when compared to the ventricular tissue, which has a very faster line versus the time period. So this is a slow process, and so this is phase 0. So during phase 0, it is called a depolarization phase, or a depolarization phase of a nodal tissue, wherein the calciums are coming in, And next is the phase 3, wherein the calcium flows at this phase, and then potassium starts, going out, efflux of the potassium, that is phase 3. Now, when compared to here, to the earlier one, we had all the phases 0, 1, 2, 3, and 4. But here we have only 4, 0, and 3, or simply called phase of depolarization, phase of repolarization, and pacemaker current, which is here. And one thing very important to you, the pacemaker current, or it's called a funny current, or the channels which are open here are called the funny channels, and which brings from the resting membrane potential to the minus 40 millivolts of the threshold. This is established by sodium, but the most important depolarization takes place only by the calcium ions here, and not by the sodium. And sodium is the initial stimulus, or it is called early spontaneous depolarization, early depolarization. But the most important, they need calcium gush inside calcium channels to open for the depolarization activity in the nodal tissues. So that's the difference between either of these, with different phases which they have. Let me come back to this picture. That you find the difference between the pacemaker currents and the ventricular tissues. That shows us the activity. So let's go back. So to the AV nodal tissue or the sinoatrial node. If there is an effect of sympathetic or a parasympathetic, for example, you give an adrenaline injection, what happens? There is a sympathetic activity. Only the pacemaker current is moved. For example, this is a normal kind of conduction activity by the sinoatrial node. If at all injection adrenaline is given at this point, what happens? The curve is shifted to the left, and due to the sympathetic activity, and there is a decrease in phase 4. That means the funny currents, the pacemaker current is the funny channels are hyperactivated to decrease its time period, and there is more funny channels open, so that gush of sodium takes in and then bringing the curve to the left side. If there is parasympathetic activity, so what happens? Acetylcholine, more availability of acetylcholine is called a vagal stimulation. Let's call this, and the curve is shifted towards the right side. So it takes a bit longer time, causing it might be a brady conduction, or this side in sympathetic activity, a tachycardic conduction. So that's what happens. Now let's go to this picture for understanding that after the concept of action potential, we are going into the phase of whereby we see different kind of waves and ECG ups and downs and all. We should understand why there is ups and downs in this ECG, and for this credits, all of the credits with his hard work, William Beethoven, who has been working from 1903 and in the long run to discover the mechanism of electrocardiogram with all his different instruments or wires or buckets. You should normally see a picture of that. I didn't want to post here, but now still what he has discovered, this ECG machines these days are so compact, and now all our diagnosis now is depending on this ECG machine. Simple what he has discovered, still we are trying to understand this ECG, and rather we are trying to ask every patient to get an ECG done in every case of admission to either cardiology or different surgeries or any department. First thing what we do, get an ECG done to find an abnormal. That's how the most common lab procedure. So we have to understand this lab. Now thing is, ECG or EKG is the same thing. Electrocardiograph. Graph is a machine. Gram is a recording of the events, and this recording of the electrical events of the heart which is taking place is recorded on a paper. That's nothing but an ECG. Now to understand the Beethoven's triangle, how we is connected with different spots of the heart, or to find the potential difference between the current flowing from let's consider sinoatrial node down to the different tissues, from the atrium to the AV nodal and to the ventricles, and we have connected this kind of triangle connecting the tissue from the right. Whatever you record the electrical activity from the right hand, or right side of the heart, for example, you record from this point, is same as you are recording what is recorded here. So we should understand body is a good conductor of electricity. So wise, either you record it here or here, doesn't matter. For example, if you record directly putting on the surface of inside on the surface of the heart tissue directly, your voltage will be high when compared to recording it outside here. So we cannot do it every time. So it is not an internal procedure to be done. So external recording is done to be picked up on the surface. So this is what we see of connecting the heart with first limb. This is called a limb lead. First one is connecting the right side, right arm towards the left arm. Right arm is always taken as a negative charge, and left arm now is taken a positive one. When compared to lead to right arm to the left leg, and although right leg is taken a neutral lead, and left leg is important for us because that's where the heart movement of the activity, the currents is taking place down here. So that's called a lead 2, whereas still right arm is taken as a negative electrode, and the other one which is opposite will be taken as a positive electrode. Lead 3, we are taking the left arm as a negative, and the left low limb is always a positive. So that is what Ethowens tells, that if we know the potential difference of uh, two of these, the third one can be automatically diagnosed. What he says is the sum of all these potential difference should be 0. So if we get one of these in a positive or a negative sign, that is very important for us. So we can diagnose what is the third lead. So that's what Ethiopian triangle tells us. And once again, a revision of conduction system. I won't go deep into it. The sinoatrial node, or nodal pathways, or the AV node, or bundle of His, and rather conducting the right and left bundle through the Purkinje fibers. And the pacemakers of the heart, the sinoatrial node, is the primary pacemaker or dominant pacemaker with the intrinsic heart rate of 60 to 100. So that's what we say, normal heart rate is always between 60 to 100, depending on the pacing activity of the sinoatrial node. So it might pace up sometimes high, depending on whatever we have seen. A sympathetic activity is you're in anger, the sinoatrial node now paced up because of the sympathetic stimulation to that area, and then you're paced up around 190 or 100 sometimes. And if that does not function, it goes, the activity is taken over by the AV nodal, which is a backup pacemaker, which conducts from for a rate of 60 to 40 to 60. And then if that does not function, there is a ventricular cells always giving a backup only to the ventricular tissue. That means that if these two don't function, the atrial conduction is almost done and not functioning. Certain amount of atrial cells also might conduct electricity if these don't function. Okay, that can be abnormal as well, but a ventricular backup pacemaker is always there, which is conducting 20 to 45 and approximately 20 to 40 like that. So that is what we should be knowing about this. So let's take about an ECG. What really happens? Here is shown a picture to you in the corner. Someone like to tell me what is this? What is this in the corner on the right side?
Voltmeter, sir. Is it a voltmeter?
Voltmeter. Yeah, well, yes, it's a voltmeter. It's called galvanometer. So you might have seen this instrument, a small instrument like this. When somebody wants to check your power at home, they bring something, wires, two wires, put it onto this and check if there is a needle fluctuation. If there is no needle fluctuation, you understand there is no electricity or there is no conduction of electricity over there. That is called a galvanometer. That is a secret behind all the ECGs, the galvanometer. In this, you see there is one side a positive note of numbers, and other side you have a negative note of numbers which is seen. This side negative and the other side. Now what we did is we connect this galvanometer is a instrument which is used for ECG, modified galvanometers, instrument which is used for ECG to understand how the stimulation of the heart is taken over and how electricity is conducted through different tissues in the heart. For that, they should be conductor of galvanometer, two different phases. Like this, conduct wires like this to different phases of the heart, the limb leads, and we have all these days we have 12 leaded ECG machines. Although we connected chest leads, limb leads, or augmentation leads, which is a different topic and this takes a rather time. but I will try to just come over with this simple things how ECG changes takes place. Now the first one is we are talking about sinoatrial node. First, let me tell you there is a negative charge connection here. I mean negative electrode which is connected to the galvanometer which is present here. One side a negative electrode and other side we are connecting with a positive electrode down here. Two wires from top of the heart, which is the right side, right arm on one side, and the left lower limb on the other side. We are connecting with a negative and a positive correspondingly to this. And the when they are conducting, the sinoatrial node is conducting or starting giving a firing of events. It passes through the nodal pathway, internodal pathway, and also to the tissue around here in all the areas. So first tissue where it will conduct to the right because it is present here. Where is it? It is present at the junction. Okay, at this point of superior vena cava joining to the right atrium, and that's its present sinoatrial node is present there. Natural pacemaker. When it starts firing, first plates to get cells activated is the first order cells which are present here in this line. Next is second order cells. Likewise, the electricity is conducted all through in different areas like this. So the first order cells should definitely be in the right atrium. So first to be get stimulated or depolarized will be the right atrium. So in the ECG, whatever you get a recording, for example, let's see there is a firing in this place, a sinoatrial node fires. And the right immediately what happens? Action potential, I mean depolarization starts in the atrium, atrial tissue first. Okay, so now we'll divide this atrial tissue. Whatever events happen, when there is a P wave, you should understand that there is a deflection, rather something called a smaller deflection here, not a big wave, smaller wave, because just because atrial tissue is smaller when compared to the ventricular tissue, and the conduction is atrium is a bit slower when compared to the ventricle, because conduction through this tissue, internodal tissue, is slower when compared to Purkinje tissue. Conduction is rather faster at 4 millimeters per second, is rather faster when compared to this. So here we'll understand there is a slower deflection, but a certain amount of higher deflection, but a slower wave. So here in a P wave, when there is a deflection, we understand that is atrial depolarization has taken place. Early atrial depolarization is just because early tissue which gets depolarized is right atrium. When compared to a bit later, at the same time, almost within few milliseconds, the left atrium also gets depolarized. So the first wave in the P wave, first part of it which tells is a right atrial activation or depolarization. In the late phase of a P, it is left atrial. But why it is a positive deflection? It is just because the current is flowing, positive current is flowing towards a positive electrode, and positive current which is spreading, I mean the cells are becoming positive in charge inside when compared to the outside, because sodium is coming in, positive current are flowing inside the cell. So we detect positive current flowing towards the positive, we have a positive wave deflection towards the up, and slower deflection but a bit larger, but not very smaller. Okay, not very larger when compared to the ventricles here, but slower deflection. And then once it goes up, half of it is activated, half of the ventricle, half of the atrium is activated, and going to the second half. So it is after that it is returning back. A needle has to go up in a galvanometer, it has to go up for some time, and eventually it has to come down after some time. So that is called a P wave, so called the atrial depolarization. Now what happens after the atrium is depolarized? Next what happens? The repolarization activity should start, but by the time the ventricle atrium is getting repolarized, there is one other activity. The electricity is already conducted to the AV nodal tissue, and from there AV nodal tissue are very smaller tissue, smaller cells inside with less number of gap junction. Current is conducted a bit slowly here in this tissue, and next to the bundle of his, or the AV nodal bundle which comes, or is called a bundle of his, and current during this time it is flowing here, and this is the phase where it is called a straight line. The current here is not picked up by the electrical, galvanometer outside, because the current is flowing very slowly inside this, and we call this an AV nodal silence, or sometimes straight away call it isoelectric line. Some electric line which is isoelectrical, a straight line should always be called an isoelectric line. And after that, that activation here, when it is activity is going on here, what you should understand, there is an isoelectrical activity, but the activity is taking place where? In the AV nodal tissue or the bundle of his. During the current is transformed, is being conducted from the atrium through the internodal pathways into the AV node and to the bundle of his. So isoelectric line is developed because there is an AV nodal silence in the AV nodal bundle or the tissue over here, and which our leads on the top cannot be picked up by by the electrical events, could not be picked up on the surface leads of the body. So that you should understand. After that, after the straight line, we'll go back, see some kind of negative wave here and a positive wave and some kind of negative wave here. So we should understand there is a QRS complex. You should understand here from this point that there is an electrical activity which has already come out of the nodal tissue from here, bundle of his, and is transferred into the right bundle branches and also to the right bundle and the left bundle. You see the color in the right bundle branch is a bit right, it is red, and left also it is red up to certain point. After certain point it is green, because this is all insulated. From here the electricity is conducted, and from behind the surface electricity is conducted. Why it is green, once again I explain you. But before that, let's divide the ventricular tissue into three different parts. The first one, ventricular tissue, is divided into three different parts. What you should understand, that ventricular tissue has divided into three parts by that it has electrical conduction in the form of early part A, that is septal part of the ventricle, major ventricular part, and base of the ventricles on either sides, right ventricular base, left ventricular base. So now once again I repeat to tell you, ventricle has three parts: the septum of the ventricle, major ventricular part, and the base of the ventricles. When there is a septum of the ventricle, which is the electricity event of the septum of the ventricle, the current is supplied only by the left bundle branches, not by the right bundle branch. That's why here it is red, insulated stuff, and here it is green, so that electrical activity is conducted in the direction towards up. Let me show you the direction, movement of the direction from here is that current is flowing from here into towards this direction in the septum, covering all the septum tissue, and from here also to here, okay, covering the septal tissue, but the net current is towards upwards. So now what we have to say, the net movement of ions is that there is a positive charge which is flowing out, positive current which is flowing out, positive current which is flowing out towards the negative electrode which is on the top. Positive current flowing towards the negative. The deflection of the needle, first deflection of the needle is when there is a positive towards the negative, the deflection of the needle will be a negative deflection. That's why we have a wave with a negative deflection. That's, please remember that, a wave with a negative deflection, first deflection which is negative, because the positive current is flowing to the negative electrode, we have Q wave. Once again to tell you, Q wave is a depolarization of the septum of the ventricles. So, and the next, after the depolarization of the septum, now it has come back to this back line, once again to the isoelectric line, but not lasting forever. Immediately, the next part which should be depolarized is the major ventricular part. This part over here is called a major ventricular part, or this tissue is called a major ventricular part. Okay, so the second part of the ventricle is major ventricular part. It is thicker on the left side when compared to the right side. That we know the reason, because right is just pumping blood to the pulmonary, where the left is pumping blood to all over the body tissues. Okay, so it should be stronger because it is pumping all over the body, so it has more thicker tissue So conduction of electricity is taking place in this direction. What direction? Once again, I repeat, conduction of electricity is taking place. The net conduction of electricity, although electricity is flowing in all the directions, net conduction of electricity is taking in this direction, but current is going all in this direction as well. But since it draws stronger tissue, the net current is flowing towards the bottom, which is a positive current flowing towards a positive electrode. Immediately we have a positive deflection of the needle. That's for your understanding why we have a positive deflection of the needle. So that is called R wave, whereas a positive current flowing towards a positive gives a positive wave. And why it is a big wave, very big wave, and a faster wave? Because we have a Purkinje fiber which is conducting very faster, and the other thing is ventricular tissue is a thicker tissue, more cells are activated, so more number of gap junction. So we have movement of needle here very fast from here to here in R wave. After the R wave and after the major ventricular is completely depolarized, what is the next part to be depolarized? The base of the ventricles. Now, base of the ventricle, which is the basal part of the ventricle, I'll use this point once again. The base part of the ventricle is this one, base part of the ventricle, sorry. The base of the ventricle is this part and on either side, but the net current, since this is stronger, net current is flowing towards the upward direction. So net current for this is flowing towards the upward direction. Back in this side, I mean to tell you, positive current is flowing towards which electrode? Negative electrode, which is here on the top. It is also positive current flowing towards the negative electrode, because this is still a depolarization activity is taking place. When there is positive current flowing towards the negative electrode, once again I told you it is a negative deflection. So in this, totally to tell you, there are three phases in the ventricular depolarization. First phase is septum of the ventricle. Second phase is major ventricular part. Third phase is the base of the ventricles. So it is called QRS complex. When somebody asks you what is Q, you should be able to explain it. It's septum of the ventricle which is getting depolarized. R, because it is more thicker tissue, we have a big deflection, faster deflection. Needle is going very high, very fast and coming back to the isoelectric line, but immediately notwithstanding the isoelectric line, there is a base of the ventricle which is depolarization. So otherwise the QRS complex as a whole is a QRS complex with three waves that it is telling us that is the ventricular part which is getting depolarized. After depolarization, what do you have? The activity stands as the ventricular repolarization which should take place. And this here matches with the picture besides you here on the top. You have a picture below here, might be on the right side, which I have to see when compared to the topper ones here over here. Right on the right of your picture, there is an ECG, and below is an action potential, which matches this. A depolarization activity wave is going up high here, and which is matching with the bottom image here on the right side. And then we have a plateau phase which is matching with the isoelectric line here. Isoelectric line here, there's an isoelectric line, matching line, that is called a plateau phase. Means in the plateau phase, we should understand, we have talked that calcium and potassium are balancing each other. So there is repolarization activity going on, but still a balanced repolarization or a plateau phase. After that, we have isolated repolarization or rapid repolarization activity, which is causing a T wave. Why a T wave is positive? Just because the current now, which has gone down into the tissue, has to come back. Now, down what is gone is the depolarization, which is positively charged. Now, repolarization is activity which is going back towards coming from a epicardial tissue back to the subendocardial tissue. So the current is flowing. Negative current is for repolarization activity. Let me show you again. Repolarization activity is the kind of negative current. A negative current is flowing back in this direction, not the positive current, because it is repolarization. Negative current is flowing back in this direction with a negatively charged, negatively current flowing towards a negative charged electrode. the deflection will be positive deflection. Now you understand why there is a T wave positive deflection. Once again, I'll tell you, a positive current flowing towards a positive electrode, positive deflection, and negative current flowing towards the negative electrode is a positive deflection, but positive current flowing towards the negative electrode is a negative deflection. That you should know why we have different waves deflecting on the top or in the bottom, which is shown to you by the galvanometer moving up and down. So as a whole, let's sum up taking in this picture in the ECG why we have got a negative waves. In this picture, why we have P wave is representing what? Atrial depolarization, and then from here onwards we have isoelectric line, which is telling us that there is activity. Where is activity going on in the isoelectric line? Let me have some interaction. Activity going on in the isoelectric line. Am I sounding enough? What is the activity going in the isoelectric line?
Atrioventricular silencing.
Okay, AV silencing, nodal silencing, or the current is flowing in the
Nodal delay.
AV nodal tissue. Very good. Nodal tissue. Okay, it is going in the nodal tissue, AV nodal bundle or the tissue or AV node or bundle of KISS. That's what the current is going. And the silence is just because it is not being able to pick up by the surface electrodes, the current. That's why next is QRS. We know what is Q, what is R, why is the deflection negative in Q, why is the deflection positive in R. Deflection S wave is telling us what? The base of the ventricles. And coming back to the isoelectric line, which is telling us this is the plateau phase. Isoelectric line is the plateau phase, the balance between calcium and the potassium. And we have a positive reflection of T wave, which is because it is more than the P wave. Why? Because it's a ventricular tissue. It is thicker than the atrial tissue. Repolarization takes place with a bigger wave. Okay, in a ventricular. That's why it's a bigger wave when compared to the P wave. So after the action is completed, we have back to the isoelectric line or a resting membrane potential. So we like to call it a maintenance of the transmembrane potential by the sodium potassium AT phases or maintained further by the potassium ions in the phase 4. So we have seen this is what is this phase in action potential. This is phase 0. I mean depolarization. Next is early. Here we'll have early phase of phase 1 and phase 2, which a plateau phase, and rapid repolarization phase 3 as compared to the action potential that we should understand the below in this side of the picture. So that is describing with the different events which are taking place. Let me sum up, removing all this, erasing all these things here. The P wave, atrial depolarization, and then isoelectric line, the PR segment, which is the time to travel from AV nodal to the ventricles before it enters to the ventricle. That is unto the ventricle, up to the ventricle. That's called AV nodal silence or the, isoelectric line. Let me not use the terms segments yet, but QRS waves. You see, there sometimes there might not be a Q wave here as seen in the right side of the picture here, because certain leads from the side might not pick up the Q wave properly. If Q wave is more than 1/4 of the R wave, then it is abnormal. Should be very small relative, because septum is very smaller tissue when compared to the major ventricular tissue. It should not, septum should not be bigger. So if it is bigger, it's wasting a lot of time for electricity, spreading of electrical impulse. That will be a problem for us. So septum should not be very thicker. So when compared to the major ventricular part, and this is also the next, the base of the ventricles. This is not as big size as this, but smaller bit, not as shown here. But next is isoelectric line once again here. Now after this, let me go back to this, talking about certain intervals and waves. What are the different waves? First, let's see about only the waves. The P wave. P wave is only atrial depolarization. Okay. Next is there is isoelectric line, and then there is QRS wave, Q wave, R wave, S wave, and then isoelectric line, and then there is a T wave. So here, what is the atrial activity is shown here? Only atrial activity, atrial depolarization. But here, let's see what happened to the, and here we see that there is a ventricular depolarization here and also ventricular repolarization. But what happened to the atrial repolarization? Please respond what happened to the atrial repolarization. What will happen to the atrial repolarization? And where is that actually?
Is overlap.
Very good. It is called overlapping or being masked by this ventricular activity. So there is an atrial depolarization, but no further atrial repolarization, which normally happens. But here it is masked over by this ventricular depolarization. Masked over, not seen, but there is presence of atrial repolarization, but not seen here. Okay, so somebody asks you a question: what are the events which are not seen in the ECG? That is simply atrial repolarization cannot be seen in ECG because it is one reason behind it is masking over by the ventricular dipole or the repole. Okay, so next we have talked about waves: one P wave, QRS, T wave. Okay, and sometimes we might find an extra wave here in this lead, something called a U wave. Very rarely you might find a U wave. If you can find a P wave next, then you can understand this is U wave. If sometimes they should be isoelectric line followed by P wave, and U wave will not be seen. But U wave is an activity of repolarization of the bundle of His or Purkinje fibers sometimes generates a U wave which can be normal. Okay, so that you should understand why it is normal. A U wave can be seen, and it should not be misunderstood if a very next P wave is there. Okay, so after waves, let's also sum up with the tissues that we should have something called a segment, and an interval. Let me not talk about interval, but let me talk about a segment. Segment is nothing but any isoelectric line. Any isoelectric line, a straight line here is called a segment. So the first segment you see is a PR segment. Only after P, I mean segments are only straight lines, isoelectric lines. End of P to the beginning of Q or R, because sometimes Q might not be seen, I've told you, or R, beginning of R. Okay, that is called PR segment. And the next segment is ST segment. End of S to beginning of T is called ST segment. Segments are isoelectric lines. What is events matter? This is plateau phase, we know what it is, and it is PR segment, we know what it is. I won't go into detail. Next, again, we have something called intervals. Let's not forget, interval is a combination of one or two waves, or one wave plus an interval plus a segment. So here we call it as PR segment in this color, from interval from beginning of a P wave to beginning of R wave. Okay, so beginning of R wave. Okay, so what does this cover? One wave, that is P wave plus one segment. One wave plus one segment is PR interval. What is PR interval telling us? Right from the current which has entered into the atrial tissue to the onset of just the entrance of current to the ventricular tissue. Not after the entrance, but to the entrance, door, exit door, I mean entrance door to the ventricular tissue. That is PR interval. Okay, next you have some other segment called we'll understand this is QT interval, which is very important, which is a combination of three different waves or QRS wave. Simply call it QRS wave, and it is also called QRS interval sometimes, and let's call it a QT interval. QT interval, which is involving three different waves plus one segment over here plus one more wave over here. So one big wave, which is QRS wave, plus one segment plus one T wave. So what is QT interval telling us? The QT interval is always telling us heart muscle. It is taking a longer time, prolonged time. It is telling us the depolarization activity of the ventricle, and the repolarization, it is involving all the phases: phase 0, phase 1, phase 2, phase 3, and also phase 4, and onset of this again. So it is QT interval is telling us the current is entering the ventricles, and the current is conducted through the ventricles, and repolarization activity. So after the depolarization, immediately contraction starts within a few milliseconds, and then Repolarization, relaxation also starts and ends up here, all of them. So contraction and relaxation also starts at the heart and ends, relaxation also ends in this QT interval. This QT interval is very important for us, and its time period is casting somewhere between 0.4 to 0.45, maximum of 0.5 sometimes in females. Why this is very important for us? Just because of one reason, that if QT interval is prolonged, the heart muscle is taking a longer than a normal to recharge between beats. That's very important for us. It should not take longer than normal. That's what QT interval. So heard of recently of a drug which is very has become very famous. The HCQs is very dangerous because it prolongs the QT intervals. So sometimes when you start an HCQ, you should have a prior ECG, and after taking an HCQ, because it can be damaging for some people, causing extra time of QT, increasing time of QT interval, that is the heart muscle to take a longer time than the normal to recharge itself. Recharging. So if that is the condition, it is dangerous. Few people can sustain those, and that's not a problem. Okay, so that is about QT intervals. We have talked about waves. We have talked about segments, which are only isoelectric line. We have talked about intervals. That is something called a TP interval or TP segment is also isoelectric line. Activity after a T wave to the beginning of a P wave is called TP segment. This one not very important, but it is relatively sometimes this TP segment is asked in USMLE exams, not in any other exams, because they are profound asking about the rest period from a beat to the one beat, end of one heartbeat to the initiation of the next heartbeat. That's called a TP segment. Okay, that's why it is relevant and more important to us. And time is getting closer. I cannot take a longer time. But before that, seeing there's something called standardization in ECG. The ECG normally graph paper looks like this, empty paper. And there is something called a standardization where we call a vertical is top of one, a horizontal one is taking the time, vertical is taking the amplitude, how much it is. The time period is the ECG paper moves at 25 mm per second. 1 second, there is a movement of 25 millimeters. And the amplitude, 1 millivolt is 10 mm in height. So whenever you see an ECG paper, in the bottom here will be mentioned the speed of the paper, because it's very important. You want to calculate the normal speed, it should be at 25 mm. If something is 50 mm, it is a bit faster, you get confused. So always see below the ECG paper will be mentioned the ECG speed and the amplitude. So if the amplitude is 10 mm per millivolt, it is called normal standardization. If amplitude is 5 mm, it is half standardization. If it is twice the normal, it is 20 millimeters per millivolt, it is high standardization. Normally, we always consider ECG should be at a normal standardization, which is 10 mm per millivolt, which is also mentioned here. These two important points should be mentioned here. And when the speed of the ECG rolling paper is 25 mm per second, that means that it should be flowing during 1 minute. There should be ECG paper moving around 300 big boxes. Once again, I tell you, this is a big box which consists of five small boxes in either of the sides. This side. Okay, this side. Okay, vertical or bottom. You cannot count 25 now. You have seconds time period in this line. So count only 5, and you have 5 small boxes for a big box here. So ECG paper moves around 300 big boxes per 1 minute. So that is 300 big boxes movement in 1 minute. That's nothing but 60 seconds. So one big box time taken is 60 by 300 is 1/5, that is 0.2. Okay, one big box is taking 5 small boxes, which it has 5 small boxes taking 0.2 seconds. So for one small box which is here, so this is taking a time period of 0.2 seconds. If one small box is considered, which has one big box has 5 small boxes, so one small box, what is the speed of it? It is considered to be 0.2 by 5, which is 0.04, which is taking the speed in of one small box only. That's how we calculate the speeds. This is, you see, one big box is taking 0.2 and one small box is taking 0.04, because this is very relevant and important when you are calculating the speeds. This is the paper vertically or horizontally describing the time and the voltage respectively. So if you want to calculate in milliseconds, sometimes you this abroad all the examinations will have to give you in milliseconds. So multiply that into 1000 milliseconds for 1 second. So you get it either in 200 or 250 or 300, 350. Normal ECG recordings on the top you will have milliseconds only. That's very important for us. Okay, for calibration. So normal ECG is like this looking. We call it normal sinus rhythm because all the waves are present in a proper manner. P, Q, R, S, T, everything is seen in a next wave is also having P, Q, R, S, T. Or should be a sinus rhythm is something which has all the waves in a systematic order, systematic manner. Or in, for example, you have taken a lead 2, everything should be in a systematic way. P followed by some segment, followed by QRS, followed by isoelectric line here, so-called the segment here, and T wave is also there. So followed by an TP segment, which is isoelectric line, again the resting of the heart, again the sinoatrial node fires, and again there's a wave in a proper way. So we call it as a normal sinus rhythm. Any ECG you pick up, first thing you have to see what is the rhythm of the ECG. That's what you need to see. So the rate which you have talked about, the rate of the heart should be between 60 to 100 because it's the rate of a sinoatrial node. If somebody has a heart rate of 62, you call it normal heart rate. Somebody has 98, also normal because the sinoatrial node is firing between 60 to 100, you call it as a normal. You don't need to treat it, rather observe it sometimes. If it is flowing above 100, you call it a tachycardia. Below 60, you call bradycardia. And few sportsmen have bradycardia. For a prolonged exercise, they have good fitness and prolonged period, minimum of 5 to 10 years, they have sinus bradycardia, which is normal for them. So that's the ECG. And I think the time is getting closer, and we'll just have a final point on calculation of heart rate. So how do you calculate a heart rate? Is taking down the rate of RR interval. Okay, how much you have. So in this picture, it's very clearly shown the gap between RR. If you're counting first thing in this blue one shown, when you're counting the small squares, see, small squares are considered, when you're counting the small square, which is more accurate, be more accurate. As a student, you should be more accurate in the examination. Always to take a small square to calculate. When you want to calculate RR interval with the number of small squares, there you count them, put 1500 by number of small squares is nothing but you get this. Because why? Because 1500 is nothing but how many big squares it has? 300 big squares. So you want to be more exact, 300 big squares is nothing but 1500 small squares. Because one big square consists of 5 small squares. ECG moves at 300 big boxes per 1 minute. So we are taking this into calculation and counting 1500 over 27, which is the number of small boxes here, and calculate with, if the rate is regular, only you calculate in this model. If you're an expert in the further after your in a PG education, you can use this big box, which is not more accurate. You might be missing certain number of small boxes in between. So this you might not sometimes get exact, because if it is exactly figured out to be the same, and you want to be exactly right, always use this 1500 over the number of small boxes, not this using the larger one. Larger one is for approximation. And the next one, you can use the next one because normally when you count the heart rate of a person or a pulse of a person, we calculate for might be 10 seconds or 6 seconds and multiply into 10 or into 6, whichever is feasible for us after being an expert. The next one is, if there is an irregular rhythm, how do you calculate a heart rate? Number, for example, you have to take 30 big boxes. For example, from here to here, there are 30 big boxes. Let's consider, for example, from this point to this point, there are 30 big boxes, and then you're calculating a heart rate because rhythm is irregular. Here it is regular, but when it is irregular, if you are calculating the heart rate, you should understand the number of R's should be calculated like this: 1, 2, 3, 4, 5, 6, 7. So there are 7 in this, but they are irregular. So you multiply, you have taken 30 boxes, which is equal to 6 seconds. Multiply that 7 into 10, which is 70. Although the rhythm is irregular, 1 hour is here, 1 hour is here, 1 hour next very close, and you might find that irregular rhythm. Always use this technique of counting RRs for 30 boxes. Why 30 boxes? Big boxes, because it is for 6 seconds. Okay, that is the minimum, because we cannot count all 300 big boxes, which takes 3 or 4 ECG papers for us, and it is difficult to count all the 300 boxes. Taking 5 or 6 papers, counting all of them will be a difficult job for you. So 30 big boxes should be considered, and number of RRs into into 10. Okay, because you are taking for 60 seconds, you are counting for 6 seconds, into 10 is 60 seconds, which you get for a minute, and the rate. Okay, now let's go for a final last minute review. So in this ECG, I want a few of you or all of you to calculate the heart rate. Is there a sinus rhythm? Now, few of you will tell me, is there a sinus rhythm in this? Please respond. Normal sinus rhythm or not?
No,
Let's take
no,
one
sir.
wave. Let's not confuse with small voltage here. Let's take one wave. Let's take 2 or this one, whichever. Is there a normal sinus rhythm in this? There's the P wave. Yes or no? Yes. There's the QRS wave.
Yes.
Yes.
Sir.
And there's the T wave. Yes.
Sir.
And there's a P wave again. QRS. There's a T wave again. And this is called a normal sinus rhythm. Now, after checking a normal sinus rhythm, your ECG report is normal sinus rhythm. And next, write what's the heart rate. Now, count the heart rate. As a student or a medical student, until you have become a professional, always use the method of 1500 by the number of small boxes. Experts, okay, 300 by number of big boxes is okay. But for students, count the small boxes. How many are there? Now come out with an approximate one. You cannot be so exact. It is needed, obviously, exactness. So what is it? 1500 by 1500 by the amount. You got it as 60 or 62, something like that, isn't it? Yeah.
26.
Yeah. Yeah. It is right. Dilip.
66.
60. So that is right. So that is 60 is the normal heart rate. So heart rate, you'll mention it. Normal heart rate, and you'll write 60 per minute, comma, regular sinus rhythm. That's what you have to mention here. And next one, next ECG. Let's not let's do it a bit faster. Normal sinus rhythm or not? All the waves are seen. Yes. Yeah. P wave is seen. QRS is seen. T wave is seen. Okay. So we call it as the normal sinus rhythm. Now calculate the heart rate. Oh, you're using a chat box. I didn't see that. Yes. Very good. The heart rate is that much. Very good. Venu, Bhargavi and Venkatesh, all of you are right. Your heart rate is 100 here. And what do you, if it is 100, it is normal. If it is above that mark, definitely it is, we'll call it as abnormal, or call it as sinus tachycardia, not abnormal. Okay, we call it, because we have a normal sinus rhythm here, we call it as a sinus tachycardia. Okay, which is rather sometimes, depending on the situation, is also a normal wave, sinus tachycardia. Okay, So let's see. After this, let me wind up with the session because I'm taking actually longer. If you have some doubts, first come out with the doubts. So we'll have a different session of separate ECG session. I think I'll take, or Chalam sir along with Chalam sir will take that session with an abnormal ECG. And now I expect some questions with abnormal ECG will be in the form of blocks. We're not talking about blocks today, or escape rhythms, or supraventricular tachycardias, or if the P wave is absent, what happens? Flutters, atrial flutter, or something. If at all a P wave is absent here and QRS is regularly coming, no P wave, what do you say? That is
atrial fibrillation.
now if the P wave is absent, here you call it as AF, atrial fibrillation. Okay, so because the P wave is atrial is fibrillating so fast, there is no proper P wave seen. Okay, that you can consider that way. Okay, there are different models that way. We'll call about an abnormal ECGs also in the later session. Any question from your side in the due time? Sir, how much difference is there between RR intervals in considering irregular rhythm? Yeah, there's some question by one of the user. How much difference in between RR intervals is considered irregular rhythm? Sir, okay, fine. When you're taking an irregular rhythm is something called with improper waves, and also RR intervals, some might be faster, some might be very slow, there's a sinus nodal, so-called a nodal dysfunction, sinus nodal dysfunction. If there is no proper nodal conduction of electricity, you will have to go back into a block. No RR interval, that's why I'm telling you, you have to calculate for 30 boxes to know whether it is conducting regularly or irregularly. Not regularly, but arrhythmias, sinus arrhythmias. So to check the heart rate, even in that condition, you have to check out with the heart rate. If it is going more abnormally below that 60 mark, as somebody has asked me, below that 60 mark, it is definitely abnormal, and you should consider that rhythm to go activate the pacemaker as such if there is irregular rhythm. So I have a question from Ramesh Bhargav. Can you explain the mechanism of reentry circuits? Fine. This is a big topic which Bhargav, I can rather tell you. When there is a conduction of electricity from one place, from here down here, that is called a single way conduction of electricity. For example, there is a conduction of electricity from this point and goes back to this point again. The electricity is being conducted in a manner that, I'll use a pen here, in a manner that the current is flowing continuously here while it is flowing. That's called reentry circuits. So in the meanwhile, this current can have tails of giving it in a different values of give current in this direction always when it is turning around, in this direction also, and again in this direction also, in the wrong way. It has to go in a single circuit or single directly. It has to enter one current is coming here, right bundle it has to go down properly, left bundle it has to go in a correct way. If sometimes there is a connection between here and the circuit is turning around here in this direction, that is called reentry circuits. Or sometimes in the nodal tissue also reentry can take place, and which can be conduction of abnormal current either to this direction also, and we have a lot of irregular waves, so called atrial arrhythmias, or we call it sinus tachycardia, sinus different waves. Supraventricular tachycardia. This is a complex topic which I should be talking about, I think, in the later classes, not now. That's for the question Ramesh Bhargav, which we'll explain in the later class, which most of you can understand if you're going too deep into the topic. I have a question from Karthik. Sir, why repolarization wave is direct from epicardium to endocardium, but endocardium is first depolarized? Let's take an example. Karthik, if at all I have a condition that let's take a rugby team and you are catching the ball and we have 10 of or 20 of our members surrounding you and all of us pump and fall on you. Okay, what happens? And you are compressed in the bottom, right? So for example, you have to get up. It means that I on the top should be getting up first, or my friends or the other team members should get up so that you get up. You're not Bahubali to throw everybody out and get up. So that's why the question asked by you, why is the repolarization? Let me pose this question to the common people, to everybody, what Karthik asked. So why is repolarization wave is direct from epicardium to endocardium, but endocardium is first depolarized? Okay, so moreover, the bottom line one cannot do it first. The superficial has to move so that give way for the bottom ones to come out. Like in a rugby team, what happens? So you hope you understood that concept over there. Okay. So any other questions? So I can take, or the others, I think they have to disperse. They have classes, most of them, and we'll get back. I promise to get back, and when we have a next session, along with whenever we have a posting of session in the later classes. With that, any questions further? Teja, any questions from your side, from all of you?
No, sir.
No. Any questions? I'm ready to answer. Even in you can give me give their mobile, give my number to them, share my number to them,
Yes.
and I can answer them in WhatsApp. Also ready to help you at any time. Okay. Hope you understood.
Yes.
And with that final message from Teja to all the HAMSA, students, so that we can
Yes.
clear off. Thank you, the students. If you have no questions, I thank you. You can always send me questions to my personal chat. Thank you very much for involving me as a part in the HAMSA team to give you given for the given topic. I think I've done justice partly and help you
Yes,
out
sir.
in increasing your academics. Thank you very much. Any
Yes.
other topic, don't hesitate to ask me. I'll be ready. But the thing is, we need adequate time, and it'll be good if you have a chalkboard rather than just talking like this. But in non-light chalkboard, I think will be difficult. I don't have that good instruments with me to use the chalkboard. I think you people are well acquainted to use a board also here. I'm just trying to use the pen note, which I have learned it yesterday or day before yesterday to help you out. So any question from your guys? So if that is up, thank you all the students for giving me this opportunity.
Thank you so much for your time, sir.